Why we did this study? When a hemophilic patient with a haemarthrosis of knee comes to our casualty, we being orthopedician always have a dilemma whether how to treat these patients. The first approach is to manage them conservatively as per the past literature and the current guidelines, that is by analgesics, limb immobilization, ice pack fomentation, and oral tranexamic acid. The other approach which we did in our study is to give an additional trial of therapeutic aspiration in addition to the routine protocol of conservative management. This is how our study began. So the aims and objectives were to evaluate functional outcome of aspiration in acute haemarthrosis of knee in hemophilic patients and to compare it with conservatively managed patients. Our study was a randomized prospective control study of 1 year duration with a sample size of 120 patients equally divided among the conservative and aspiration group of 60 each. After obtaining the demographic data and under the appropriate factor infusion of 40%, we randomly allocated the patients in 2 groups. We evaluated the patients' functional outcome on the basis of hemophilia joint health score and pain in terms of visual analog score. Our inclusion criteria, we included all the patients of age greater than 5 years for 2 reasons, one for the better objective outcome and second for a better pain tolerance. We excluded all the patients who are having haemarthrosis in any other joint except the knee, and we excluded the patients who were inhibitor positive. The reason being the factors will not be working in the patients having inhibitor positive, and we have to give an additional infusion of FIBA, that is a factor 8 inhibitor bypassing agent. So here are the 2 groups, that is a group A who were managed conservatively on analgesics, preferably paracetamol or tramadol. Nowadays we are giving etoric oxib and giving limb immobilization, ice pack fomentation. And the second group, that is the group B, we managed them with an additional trial of therapeutic aspiration in addition to the routine protocol of conservative management. Under all aseptic precaution, we aspirated the patients by the routine superolateral approach. In some of the patients in whom, for example, there was a fixed flexion deformity of the knee, we preferred to go for inferolateral or the inferomedial approach for the aspiration. After the aspiration, we again evaluated the functional outcome in the basis of hemophilic joint health score and visual analog scale at a serial interval of 4 hours, 48 hours, and 7 days. So we can see as highlighted in the result that there was a declining trend in both the groups, Group A as well as Group B. There is a declining trend in the hemophilic joint health score and the visual analog score for both the groups, but the decline in the hemophilic joint health score and the visual analog score as in Group B as compared to Group A was statistically significant. The same can be seen in a diagram, in a representation of a line diagram. There is a declining trend. There is a declining trend in both the groups, but decline in the group to whom we aspirated, that is the Group B, it is significantly better as compared to the Group A. The similar result was seen in the pain relief in the terms of visual analog scale, where we did at the serial interval of 4 hours, 48 hours, and 7 days. And the same can be represented on a line diagram. We can see initially to begin with, the VAS score was 8.7 and 8.6 respectively in both the groups, that is the Group A and the Group B. But in Group B, it was statistically significant as compared to the Group A. So what we could conclude from our study is to advocate the joint aspiration for a better pain relief and the functional outcome with having no complications, early symptomatic relief, and a better functional outcome. Thank you.